Alright, so welcome back. To kind of recap, so this patient has a mild, gently sloping to a moderate sensorineural hearing loss bilaterally, and then our main focus with the case presentation was the vestibular symptoms and assessment completed. So I gave you a compare and contrast of two evaluations that were done. In both assessments there was downbeating nystagmus in positional testing, and this did not fatigue with any of the positions, so that kind of indicates to us right there a central indication. And then Dix-Hallpike was positive for BPPV with the first assessment and negative the second time. So name that pathology. A few of the guesses that I got were really great, aligned kind of with what I would be thinking too based on what I gave you. So a few of them were a cervicogenic or, nerve compression pathology, and vertebro-basilar insufficiency, which is also a great guess as well. Okay. Now, these were a few hallmark signs that I really wanted you to take away from the case and try and figure out on your own here. So hallmark signs for this pathology that I will reveal shortly. The reported imbalance from the patient and the observed abnormal gait were big indicators, as well as the severity of symptoms worsening from the time that he came in to the next time we saw him. And now that downbeating nystagmus that's persistent in all the positional testing, again, is a central indication. So this was my next step with this patient. Now keep in mind, I already knew what the pathology I was dealing with when the patient came in. So it was easy for me to kind of figure out where I wanted to go in terms of my next steps of care. Now for those, not having that information in front of them, the next steps and plan of care that you guys gave me, I would have recommended the same things. Again, my thought process would have aligned a lot with many of yours. So a few of the things that I got were referrals to neurology, referrals to a cardiac specialist due to the congenital heart disease this patient had, so maybe some of the effects linked with that. Imaging was recommended, so either like a CT or MRI testing. And then another person wanted to know, okay, so what were ocular motor subtests? Were those normal, abnormal? Was downbeating still present in ocular motors? So here we go with rotary chair. So spontaneous nystagmus, there was an upbeating nystagmus, so that's changed a little bit there. There's not that downbeat. So we have the upbeating nystagmus, and it didn't suppress with fixation, so a central indication. Gaze testing was abnormal. Findings revealed upbeating nystagmus and corrective saccades present in all gaze condition and did not suppress with fixation. Saccade testing, same thing. Findings revealed undershooting in horizontal and vertical conditions tested, another central indication. And then smooth pursuit, abnormal. Findings revealed reduced gain, saccadic component, and there was asymmetry in both the horizontal and vertical conditions tested. More central indications. So at this point, I hope you're thinking OPKs have to be abnormal. Well, the 20 degrees per second was within normal limits. However, 40 degrees per second and 60 degrees per second, the eye velocity and velocity gain in those conditions were abnormal. Now, based on the patient's age, I would expect with that patient that the 60 degree would be something that the patient could do. However, since he was already showing abnormal results in 40 degrees, I was expecting 60 degrees per second to potentially be abnormal as well. So, moving on, we have the Shaw test. And for findings there, phase and gain were normal. However, asymmetry was abnormal. And then I listed there the frequencies that were tested. So keep in mind, and this comes right out of your book of Jacobson and Shepard, but abnormal asymmetry indicates a lack of compensation at the level of the vestibular nuclei. So thinking about that pathway all the way up to the cerebellum there. So therefore, a patient may also present with spontaneous nystagmus, positional nystagmus, and a directional preponderance. So right now we know 2 of the 3. VOR suppression, abnormal, present but reduced, falling outside normal limits. And then we have the subjective visual, vertical, horizontal. So the test for this, its purpose is specifically looking at vestibular function of primarily the otolith organ and some of the central gravireceptive pathways. So if you see abnormalities in this test, it's open to various interpretations. So it can either be both brainstem and labyrinthine site of lesion that may affect the torsional ocular system here. So more central things at this point. Now going back to name that pathology, we're adding on some additional signs here. So gaze evoke nystagmus. Typically, we see it as a lateral inferior gaze or an oblique lateral down gaze. In this case, we actually ended up seeing the lateral superior gaze and oblique lateral up gaze, however you want to refer to it. Keep in mind, gaze evoke nystagmus is due to a deficient eye position signal in the neural integrator network, so cerebellum and medulla areas. So the eyes cannot be maintained at an eccentric orbital position, so they're pulled back towards their primary position. And then that's where we see the corrective saccade that moves the eye back towards that eccentric position. Let's move on. So here we are. It is a Arnold Chiari malformation type 1. So those are some of the hallmark signs that you should be thinking of when you have an Arnold Chiari malformation type 1 patient. Sometimes it gets confused with BPPV because these patients will come in and have, one day they have BPPV, the next day you treat it, it's gone. And so then there's this reoccurrence of BPPV and the vertigo symptoms get worse and then they get better kind of thing. However, if it's very persistent and stuff, it's always recommended that you get imaging done just to make sure that there is nothing central going on. But in this case, this patient also presented with a lot of other central indications in vestibular assessments that we did. So the interesting thing about this case is that it's post-surgical, completed in 2018, and he's having these persistent symptoms, and typically in the research that I was reading about, most patients will find a lot of relief. Now, it's not completely gone after surgery, but they'll find relief from some of these symptoms after the decompression surgery. This patient reported that he did for some time, and then now things have started to act back up. So he's not really sure if maybe there's more going on at the surgical site, other nerve endings that have been affected post-surgery, or what at this point. So definitely want to recommend that this patient have more imaging completed just to make sure we're not missing something there. Just to kind of give you a recap, Arnold Chiari malformation is a problem in which part of the brain, specifically the cerebellum, at the back of the skull bulges through a normal opening in the skull where it joins with the spinal canal, and then this puts pressure on parts of the brain and spinal cord and causes mild to severe symptoms. In most cases, it's present at birth, so it is congenital. Type 1, you'll typically see it much later as the brain develops. So once it's either in that developing stage or kind of done developing is when you start seeing a lot of these symptoms come on. Now assessment, so a lot of you were kind of thinking the right thing. It is a non-localizing finding. I noted with my results that it has more indications of somewhere along the pathway of this a like brainstem site of lesion. We do have some of the peripheral indications as well, with that presence of BPPV that keeps coming and going. But my main suspicion here was that it's more primarily central findings from the data that was collected. And then something that I didn't know, but through my research found out that this population has the highest rate of benign paroxysmal positional vertigo reoccurrence. So that's just something to keep in mind. And like I said, makes it sometimes hard to diagnose these patients because you're thinking it's BPPV, it keeps coming, keeps going. But in this case, if it keeps coming and going, like I said, it might be worth it to get some further imaging done. So, last piece here, plan of care. So neurology actually sent over this consult, so I just made them an additional co-signer to ensure that they had reviewed the results that I had gotten, and just can't rule out the CNS involvement at this time. So I recommended further imaging for this patient and then either follow up with primary care or neurology, and either one that maybe they consider a referral to optometry as a starting place. They'll probably most likely refer on to ophthalmology for more ocular motor testing, probably more specifically like a neuro-ophthalmologist with some of the things that I was seeing in his VOR testing. So I'm curious to see if he'll be back in my office for continued care with the BPPV as it comes and goes. I have not gotten to see the results of the neurologist and what he recommended next, so hoping that everything's well with this gentleman. At first he came in with a cane, and the last time I saw him he was using a walker and doing much better, so hope he's doing well, and thanks for participating and listening to this case presentation. I hope you got a little bit out of it.